Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Malata from Roots Community Health Center, reporting for the week of February 5th, 2024. Following an update on COVID, flu, and RSV, I will discuss SARS-CoV-2 outpatient treatments, including some recent findings. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. COVID is still with us. It is still causing sickness, disability, and death, and there is still a lot we don't know. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Starting off with wastewater, nationally, viral activity for COVID is very high. And the national average is shown there in the black line, so it does appear to be coming down nicely. But the region with the highest wastewater SARS-CoV-2 levels is the South, which is shown there in the purple line. And not only is the South the highest, it also appears to be heading straight back up. So a reminder that that gray shaded area is still incomplete, and we'll continue to look at it. But all the other regions of the United States are showing the same downward trend as the average shown with that black line. But again, it appears the South may have some levels that are increasing. So we'll continue to keep an eye on that. Taking a look at weekly new hospital admissions, those continue coming down. Thankfully, we are at 22,636 hospital admissions for the week of January, the week ending January 27th. That's the third week in a row where COVID hospitalizations have decreased. So let us hope that that trend continues. Still a lot of people, though, getting hospitalized each week for or with COVID. Taking a look at deaths for the week ending January 6th, we had at least 2,258 deaths in the United States, and these are from COVID. And the death numbers for the week before that actually were updated since the last time we reviewed this. And so now those are also over 2,000. So this is the sixth week in a row that deaths have been increasing, and it is the second week in a row that we have had over 2,000 deaths from COVID. Still way too many people dying from COVID each week. This is more than quadruple where we were for most of the month of July when we got down to around 500 deaths per week. But with hospitalizations starting to come down, I'm hopeful that deaths will peak soon and begin to decline again. Remember that deaths tend to follow hospitalizations by a few weeks, so we will be monitoring to see if that continues to hold true. And this is when I normally give a weekly reminder about how to prevent these hospitalizations and deaths by reducing transmission of SARS-CoV-2, staying up to date on vaccination, and with timely outpatient treatment. I'm going to talk in a lot more detail today about outpatient treatment, so we will leave it at that for now. And taking a look at variant proportions, JN1 continues taking over. Now it's almost completely taken over here in the United States, projected at 93.1% of specimens. And as we've talked about, JN.1 is highly mutated. It's very, very contagious. But so far, our vaccines and treatments continue to work well enough against JN.1 and all the other variants at this point. There have been other variants popping up here and there and here and in other parts of the world, but nothing especially concerning yet. Of course, this is an area that many are continuing to watch, and hopefully there's now enough surveillance going on here and all over the world so that if we do get anything too different, hopefully we will have the lead time to prepare for it. In the meantime, hopefully this slide will remain nice and boring for a while. Now taking a look at influenza in the United States for the week ending January 27th, 2024, and taking a look at the positive tests on the graph on the right. We were coming down, but unfortunately it does look like we're headed back up. This isn't out of the ordinary, this kind of like double dip, but it just reminds us that we are not out of the woods just yet with flu. And the week ending January 27th, there were over 12,000 patients admitted to the hospital with flu, roughly the same as the week prior to that. So far this flu season, there have been an estimated 230,000 hospitalizations and 14,000 deaths in the United States. 65 of those were pediatric deaths. And many of these deaths are preventable with the flu vaccine. It's not too late to get that. It's recommended for everyone 6 months and up. Flu season is considered to last pretty much through March or so. And especially given this second bump up here, definitely something to consider. The RSV graph continues to look a little chaotic, so we're going to skip it today. We still do have a fair bit of RSV circulating, but it does appear to be coming down, and so do the RSV hospitalizations as well. Today, I wanted to review about outpatient SARS-CoV-2 treatment. So just a reminder of the 4 approved medications we have for SARS-CoV-2. And a first-line treatment of choice for most people is still Paxlovid. It continues to work well to keep people out of the hospital and to prevent death from COVID. But unfortunately, it continues to be underprescribed, and I will talk more about that in a moment. Remdesivir is also very effective, but this one is much more difficult to get. If you're someone that for some reason really cannot take Paxlovid, but you need to be treated, I would suggest speaking with your physician about that now, getting all this arranged ahead of time. For this treatment, you have to go in 3 days in a row to get the IV treatment, and the challenge is trying to find a place near you that will do it. It's mostly hospitals that are offering this treatment on an outpatient basis at this time, if at all. And last line for most people is going to be molnupiravir. This is another oral one, so it is convenient. However, it's only around 30% effective against hospitalization and death compared to around 80% with Paxlovid. So this is definitely much more of a last resort if there's really no way you can take Paxlovid, but it is better than nothing. But you don't want to just resort to molnupiravir just because someone doesn't feel like figuring out your other medications as is required with Paxlovid. There are medication interactions with Paxlovid, but most of them can be overcome by having you hold off on those other regular medications. But this is something that does need to be done with your physician. So once again, a plan ahead of time is helpful. And for those who are immunocompromised, high titer convalescent plasma might be an option. It's worth noting that all of these treatments need to be started within 5 days, pretty much. And that's a pretty short window of time to get treatment. And actually, the sooner the better. So that is why staying vigilant, getting tested in a timely manner is so important. And as I mentioned, with the legwork needed to get all of this accomplished, this is why we always suggest having that treatment plan in advance. Do not wait to see how you feel. That is not how this works. If you're in a high risk category, even if your symptoms are mild and you're still in a high risk category, even if your symptoms are mild, and you could unfortunately move into the more dangerous phase of COVID after the initial mild infection, that's the phase that can send you to the hospital. That's the phase that can have impacts on multiple different organ systems. So we just don't want to have to get there at all. And that is the reason for outpatient treatments, is to keep you out of the hospital or having a very severe outcome. Now I want to talk about this study published in JAMA on January 26, 2024, called Clinical Risk and Outpatient Therapy Utilization for COVID-19 in the Medicare Population. So this paper is looking at outpatient treatment of COVID across patients in the Medicare program. And they were trying to get an understanding of the different factors that might explain differences in access to those outpatient treatments. They looked at the year 2022, and this is a cross-sectional study of patients enrolled in Medicare in 2022. What is a cross-sectional study? A cross-sectional study is a type of study where we are observing outcomes and exposure in a population at the same time. So this is not an experiment. We are just observing and we're looking at the outcomes, in this case, getting treated for SARS-CoV-2, and exposure in a population at the same time. So we're looking at all of the different factors that may contribute to the outcome. So it's not an experiment. And in this kind of study, it's difficult to determine cause and effect, but it is a way to look at the associations between things, and it works well for analyzing population, such as the population analyzed here, which is the Medicare population. And there are a couple helpful things about looking at the Medicare population. First off, this is a large population. It is primarily those 65 and up, as well as those on disability. So basically, a large portion of the people who are at highest risk of a bad outcome from COVID. So good population to look at when we are trying to assess access to outpatient treatment, because that's the groups that should be getting it. Secondly, the researchers were able to get a lot of information from Medicare claims, which is a helpful source of data because everything is coded and it's easier to analyze a very large data set when you have this type of data than, for example, if you had to go through individual patients' charts and read notes and things like that. And in fact, this analysis looked at over 20 million Medicare beneficiaries. And what they discovered was actually really concerning. So the outcome they were looking at again was people treated with outpatient treatment for COVID. And at that time, in 2022, in addition to the first three medications we just talked about, Paxlovid, remdesivir, and molnupiravir, we also had monoclonal antibodies, which, side note, I really, really miss monoclonal antibodies. They were very easy to use, almost no contraindications. They were quite effective and saved a lot of lives. And I look forward to the day when we have new monoclonal antibodies, but unfortunately, those left us. They're not effective on the ones we had are not effective on the current variants, and we haven't made any new ones, sadly. So keeping my fingers crossed for that to come later. We do have convalescent plasma now for a small subset of population. But at any rate, this study was looking at Paxlovid, remdesivir, molnupiravir, and monoclonals. And then they looked at a number of different patient characteristics like age, race, ethnicity, whether they resided in a nursing home, whether they lived in a rural or urban area, and whether they were also eligible for Medicaid in addition to the Medicare, which would indicate that they are low income. And here's the graph I wanted to review from this study. This type of chart is called a forest plot. And this is just a way to represent data it could be to represent data for different things. It could be to look at multiple studies, or it could be to look at multiple subpopulations or multiple different variables. In this case, we are looking at patient characteristics, which are listed there on the left. And then we're trying to understand the chances that someone with these characteristics would get treatment for COVID or not. And the line going down the middle kind of indicates that there's no effect of the patient characteristic on whether they got the treatment or not. And to the left of the line means they were less likely to get the treatment. And to the right of the line means they were more likely to get the treatment. So if we take a look at the first grouping of characteristics, that is age group. And we can see there that, interestingly enough, for the older age groups, they become less and less likely to have received the treatment the older they got. So the little square there just keeps going further over to the left, meaning less and less likely to get treated in each subsequent older age group, which is pretty much the opposite of what we would want or think, because each older age group is at an increasingly higher risk of a bad outcome. And as you can see, with each older age group after 65, the likelihood of getting treatment got to be less and less. So this is definitely problematic. As far as gender, females were very slightly more likely to be treated than men. Looking at race, we can see that by far the least likely group to receive treatment were Black patients, followed by Hispanic patients. This is a pretty stark disparity here. And in terms of geography, those in rural areas were a little less likely to receive treatment than those non-rural areas. And this part here is very concerning about Medicaid eligibility. If you're eligible for Medicaid, it means you are in a low income category. And those who have Medicaid, in addition to their Medicare, we call dually eligible or dual or Medi-Medi. And basically it just means that in addition to the Medicare, you also have Medicaid. And The folks in this dual category, meaning they're low income, were much less likely to receive treatment than those who were not. Another concerning bit here, those in nursing homes were much less likely to receive treatment. Now, this is upsetting. Why would this be? Especially when you are in a residential environment where things in theory should be more controlled, you should be able to get timely treatment, timely testing, and timely treatment. This next section is probably the only section of the graph that makes logical sense to me, which is showing that the more chronic conditions a person has, the more likely they were to get treated. And in this next section, we see that those who are vaccinated are more likely to receive treatment than those who are unvaccinated. And so, although we would like both groups to seek and get treatment, those who've never been vaccinated are actually at much greater risk of a bad outcome. So it's again odd that the unvaccinated have less treatment than the vaccinated. That could have to do with whether those folks were seeking the treatment or not, but this is still definitely a concern. And interestingly enough, here we see that people who had contraindications to the treatment, so there was some reason why they either couldn't get the treatment or there was an issue with getting the treatment, those were actually more likely to be prescribed than those who don't. And that's not necessarily a bad thing. It at least tells us that the doctors were, working with those contraindications and doing what they had to kind of mitigate those things. But what's concerning about this is that it says that the contraindications were not the reason why people didn't get treated. So it certainly leaves one to wonder why, and again, the older age groups, populations of color, low income age groups, if it wasn't the contraindications, what was it? So again, being that this is a cross-sectional study, it is observational, so we really can't determine cause and effect. But still, these are some pretty troubling associations we see here. Namely, again, those people who are at the highest risk for COVID hospitalization and death, Black and Latino, low income, adults 80 and up, those in nursing homes, those were all less likely to get COVID-19 treatments. The authors speculate that these disparities are likely to include some combination of the clinician's willingness to prescribe an antiviral as well as the patient preference. And one really interesting thing I thought that they did in this study was to do some simulations to try to quantify what things might have looked like if the people who were supposed to get treated got treated instead of those who weren't necessarily at risk. So this is kind of interesting where they assess what would be the effects of reallocating the doses to the high risk people. And they did some different scenarios, but the middle of the road scenario was what if they reallocated Paxlovid according to patient risk? They estimated that they would have avoided over 10,000 hospitalizations and over 16,500 deaths in 2022. Now, mind you, this entire analysis was looking at 2022 before commercialization of the pandemic response. So now that it's no longer as easy to get Paxlovid, there are additional barriers now compared to what there were back then. We can only anticipate that some of these issues, some of these disparities will actually get worse. And this is something I've definitely mentioned here before, that sometimes when we get the tools, kind of like what we saw with HIV, we get the tools, then we start to see disparities actually getting wider because those who have good access can access the tools. And those who, for whatever reason, do not have good access don't get to take advantage of those tools. And in this case, that would mean more hospitalizations and more deaths that could have been avoided. So the bottom line here is we have work to do. We need to do a better job at actually getting treatment to those who need it. And we should all work to avoid having this happen. We don't want this to happen to you or to a loved one. So let's make sure, if you don't have a primary care doctor, if your loved one doesn't, please get one and work with them to come up with a treatment plan now and advocate for yourself and your loved ones to get the treatment that you need. Now, I have been asked a few times to talk a little bit about metformin and COVID, and honestly, I've hesitated to do so because the data is still pretty preliminary and I don't have a lot that's conclusive to say, but there are a few different lines of evidence and there's a lot of talk out there about it. So I wanted to make sure that we at least had some of the basic information. So first off, what is metformin? Metformin is a pretty widely used medication for the treatment of type 2 diabetes. It was approved by the FDA in the United States about 30 years ago. So it's been around for a while. Actually, it was approved in Canada even a couple of decades before that. So suffice it to say, this is a pretty well-known medication. We've got a lot of experience with it. So first, I want to talk about the study published in October in The Lancet called Outpatient Treatment of COVID-19 and Incidence of Post-COVID-19 Condition over 10 months. This is otherwise known as the COVID Out trial. And as you can see here, this is a multi-center randomized quadruple blind parallel group phase 3 trial. So that was a mouthful. Let's unpack it a little bit. I think we've all heard of randomized controlled trials or double-blinded trials. Well, this is a randomized quadruple blind trial called COVID Out. And unlike the last study we just talked about, which was observational, this study is an actual trial. So this is a clinical trial where they're really doing experiments on human volunteers to see about the safety and the effectiveness of different interventions. A randomized controlled trial is looking at the effectiveness of a new intervention or treatment. And blinding is the process where one or more of the roles involved in the trial are unaware of which treatment participants have been assigned to receive. And blinding is an important aspect, a very important aspect of clinical trials, so that we can avoid any kind of bias that might come from knowing what the participant got. So it could be bias from that patient, it could be from the provider, or even from anybody else dealing with the trial at all. And I'll make a note here because I've heard a lot of confusion about this. For example, people saying, we don't have randomized double-blind controlled trials for masks, so how do you know that they work? So I'm not going to get into that topic today, but I will just make the point that you can't have a blinded trial for masks because everyone will know if the mask is on or not. So there's actually a lot of examples of instances where it doesn't make any sense to do a randomized double-blinded controlled trial, or whether it's actually impossible to do them. But a single blind trial is where the patient is unaware of what treatment they got. A double blind study is where both the patient and the researcher are unaware of the treatment the patient got. A triple blind study means the patients and the researchers and the people analyzing the data don't know which treatment the patients got. And then lastly, and then this is the case here in the COVID Out trial, a quadruple blind study is when the patients and the providers and the people assessing the outcomes and the people doing the data analysis are blinded from who is in which arm of the study or who is getting what. And this study was specifically looking at adults aged 30 to 85 years old with overweight or obesity who had COVID symptoms and a COVID PCR positive. And they were randomly assigned to one of 6 different groups, and these involved different combinations of metformin, also ivermectin, the antiparasitic drug, and fluvoxamine, which is an antidepressant medication, and placebo. And if you're interested in the different combinations in each group, you can take a look at the study, which is linked in the post. The main outcome they were looking for was severe COVID-19, and the secondary outcome they were looking at was diagnosis of long COVID. Long story short, as it related to the primary outcome they looked at, severe COVID-19 by day 14, metformin, ivermectin, or fluvoxamine did not reduce severe outcomes. So that was a little disappointing. Now, there's a lot of side notes to this, and I'm not going to get in a lot of the details, but I will just say that metformin did show promise and has shown promise in other studies for people who were already on metformin for their diabetes showing a reduced risk of severe outcomes. So there's a very clear guideline that says if you're already on metformin, do not stop it in the hospital, which is something that would often happen because oftentimes in the hospital it's just easier to control diabetes other ways. But it is clear that if you are already on metformin, you have COVID-19, you go to the hospital, you should stay on it because it does reduce the risk of a bad outcome. We don't know all the what's and the whys about this, but there are studies that are kind of corroborating this. So this is probably the one clear guideline that we can say about metformin. If you're already on it, you get COVID, stay on it. Even if you get hospitalized, they're supposed to keep you on it, but not enough to tell us that we should be giving metformin to people who are not on it for acute COVID. And so there's a nice little summary about what they found about acute COVID, which I've linked in the post. But I wanted to get to the better news, which came on the second part of the trial, which they're calling the long-term secondary outcome, which was the diagnosis of long COVID. And metformin cut the risk of long COVID by about 41%. And when it was started within 3 days of COVID symptoms, the incidence of long COVID was reduced by about 63%. So this is pretty significant. But it's always caveats and reminders here. So one reminder, the study was really looking at people who were considered overweight or obese using the BMI calculator, which we know has their limitations, but that's what the study was looking at. Also, they were only looking at people from age 30 to 85 years of age. So can we generalize these results to younger people? We don't know. Can we generalize them to people who don't have an elevated BMI? We don't know. We don't know the answer to that either. But clearly, I think we need more studies like this, actual clinical trials for long COVID. Now, this study was about preventing or was looking at preventing long COVID, not treating long COVID. So what do we think about that? So I think that this study needs to be replicated. We need to see other trials that kind of reproduce this finding so that we can feel more confident about it. And especially given how things with COVID continue to evolve and our understanding of long COVID continues to evolve, I think in the absence of that, a lot of doctors are not going to feel particularly comfortable prescribing it, especially to someone who, doesn't have diabetes or isn't overweight or obese or isn't 30 to 85. But it is a potential that some doctors will feel comfortable doing it, particularly given that there's nothing else. We have nothing else that we know of that is going to prevent or reduce the risk of long COVID. But I will just say, because we don't completely understand how it works or why it works, there's a lot of clinicians that are going to want to see a little bit more evidence, a little bit more information before feeling comfortable in just prescribing this. But it's still important information for everyone to know, and certainly good information to bring to your doctor to see what they think, because we are allowed to prescribe things off label. And like I say, metformin is something that we have a lot of experience with. It is pretty safe and well known, but all medications have potential side effects, and metformin is definitely no exception. So it is a judgment call, but I would definitely call this very promising information. The other thing I want to say about this is that we need to be doing more of these studies that look at repurposed drugs, drugs that are cheap, drugs that are easily available, because we are having an issue right now where worldwide people do not have access to antivirals, especially very expensive ones like Paxlovid. Even people here in the United States aren't going to have access with that price tag. So we've got to continue looking at better ways and new ways to address both the acute infection as well as the long-term impacts. So the authors here conclude that metformin has clinical benefits when used as an outpatient treatment for COVID-19 in reducing the risk of long COVID in particular. And it is, again, globally available, low cost, safe. And they also concluded that ivermectin and fluvoxamine do not have any impact in terms of reducing the risk of long COVID. And lastly, and I won't spend much time on this one, this is a preprint, hasn't yet been peer reviewed, but it is showing that metformin reduced the viral load of SARS-CoV-2 by 3.6-fold. So this could explain why it's effective in long COVID, maybe, or it could be because of metformin. It's known to reduce inflammation, so it could be that. We still have quite a lot to learn. There is an active trial called the Active 6 study that is looking at metformin. It's still open, and it's looking for people who are 30 years and older who have tested positive for COVID-19 less than 10 days ago and have at least 2 symptoms of COVID-19. So I've linked this study in the post, and if this is something that you're interested in. Now, we don't know which arm of the trial you would end up in, so there's always that risk, but something to consider if you do get COVID and you fall into those categories. And also, once again, something to kind of keep an eye on. Let's see how it evolves. And it might be something to let your doctor know about, because as we've seen, some of this information is a little bit slow in getting out there. But I think what most of us really want to see is these type of findings being reproduced, and so that we can feel more comfortable that it is in fact real. And even better than that would be understanding how it works and why it works. And I think as our understanding of long COVID evolves, some of this will become more clear. So until then, let's keep up our best practices to prevent the spread of all respiratory infections, but especially to prevent the spread of COVID. Let's prevent those outbreaks. Let's prevent those super spreader events, and let's prevent and slow this burden of long COVID and post-COVID events. And we can do that by masking with a high quality mask like an N95, KN95, or KF94. Let's try to gather outdoors whenever possible. Pay attention to indoor ventilation and filtration. You can even monitor your indoor air quality with the CO2 monitor, and limit our time and mixing indoors. Staying up to date on vaccination and testing, and accessing timely outpatient treatment if it's indicated for you. And let's try to avoid infection and reinfection. Remember that catching COVID once and doing fine is not a guarantee about the next time. Every infection is a new opportunity, and perhaps even a compounded opportunity for long COVID and post-COVID impacts. And if you do end up getting COVID, testing positive, in addition to that timely outpatient treatment, let's also isolate. Let's not go around others. If you absolutely must go out, then please wear a well-fitted N95 mask. Hopefully that will provide enough source control so that you will not spread what you have to others. And as usual, let's remember to eat a well-balanced diet, avoid processed foods and sugary drinks, get some regular physical activity unless you don't feel well, unless you have been diagnosed with long COVID. In that case, you really need to get your rest and get the best advice of your treating providers. If you are someone who should be treated if you get COVID, you should know that now. Advocate for yourself, advocate for your loved ones. This is preventing hospitalization and death, but is very underutilized. That must change. And remember, if you don't have a primary care provider, please get one. Get your blood pressure checked, your baseline labs checked, like sugar and cholesterol. And please manage those stress levels and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you again next Tuesday at 10 a.m.